Alrighty. I don't have any jokes. So we'll just get started, everyone. So there's a lot of techniques. I just want to get through it. I don't want to short anyone their time. I'm giving a presentation on pelvic obliquity, sacral, coccygeal joint mobilization. I took the class at IPA with Kent Kaiser. I don't know if you guys know him. I think Tony's met him. So he's a pretty well-known guy for this type of stuff. He's a really good therapist. He's really nice. So if you ever like the IPA material, I would recommend a class over there. So the basic treatment order for this type of stuff, I know you guys all already do a lot of SI type of stuff. Everyone has been exposed to it. But a lot of what we do is usually just innominate, depression, elevation, and flexion, extension. So up slip, down slip, anterior rotation, posterior rotation. That's kind of that's what everyone knows. That's the easy stuff. That's what we look at. That's what we palpate, ASIS, PICS, and we feel that. Everyone feels that, and you treat that, and usually you get pretty good results. But this type of stuff is more for like when you try that stuff and it's just not working, and you want to try something a little bit more, a little bit extra. Per the IPA recommendations, they actually recommend to start with the coccyx. So you find a patient that has this type of symptom, this type of pain back there, and they say, oh, I have pain doing this type of stuff, or whatever symptom. Like for myself, I do have a little bit of discomfort myself, but my issue is actually on my ischial tuberosity. So when I sit, I feel like I'm always off to the side. So the patient might recommend, or might say, report that they have symptoms of difficulty sitting, difficulty walking, going up and down stairs. All this type of stuff is stuff that you would just maybe direct your attention towards SI, pelvic girdle type of material. All right, so the stuff that we'll be going through today is mostly just sacrum and coccyx type of stuff here. This sacrum PA, sacrum or innominate IR, anterior sacral tissue, soft tissue. This is just the treatment order that they recommend for you to sequentially go through your progress, because this stuff, per their description, they say affects the most other structures. But versus if you look at sacrum nutation extension, this does not affect so many structures. It's kind of a thing that just always moves around so much. So when they're looking at this stuff, pubic ramus, treat that at the very end if you're still not getting enough results. So like I said, today we'll be focusing more on this up here, and there's still all this other stuff that is in the class, but I feel like we can kind of figure that out on your own or have done it before. So in terms of the coccyx, you guys have all seen this guy, okay? This is the skeleton of someone who's probably 12, right? You guys can tell it's a tiny little person. So when you feel it, it's going to be bigger than this little thing right here. And what you're feeling is this, actually, in terms of the coccyx, okay? But what it's missing actually here is two transverse processes. So it'll feel different on everyone. Some will be bigger, some will be smaller, and that's where we're kind of feeling today. Most people, we focus a lot on here because this is so close to your danger zone, right? When you treat a patient with this, always ask for permission, always ask for consent, okay? How's everyone comfort-wise where this is on the body? Anyone? Uncomfortable?
About where it is?
Yeah. You guys don't know where it is. If you feel on yourself right now, on your cleft, right above your midline, you should feel that, all right? And what you're probably feeling, though, is here, right? Your sacral cornu. I don't know if you guys know that. So,
right above your butt.
Right, yeah. So actually, if you go a little bit more, do you guys feel, okay, I want to see one person feeling. I don't know. Yeah. All right, feel yourself, guys. It's more comfortable. Gets the jitters out, because you guys will be feeling this on each other, actually. That's the point of today, for you guys to be...
Here's mine.
Yeah, so if you feel it, yeah, it's all the way down there. And then if you keep traveling anteriorly, you'll feel like a little pencil tip, or like the back of an eraser on the pencil. You'll feel that right at the bottom underneath, okay? So that is your base of the coccyx. So when we're palpating a lot, this is very sensitive, obviously, right? We don't want to fracture this guy. What we'll be feeling more is here and here, the transverse processes of your coccyx, or of your patient's coccyx, okay? Everyone okay with this so far? So in terms of, let's see. Did I delete the slide? Okay, so in terms of their treatment order, they feel that it affects the most other structures, because when you affect the base of support, it connects everything else. So you're looking at other stuff where it improves the lumbopelvic motion. You come in with a patient with back pain. Yeah, you don't think to often go towards all the way down to the sacrum and the coccyx, but if you address that with lumbopelvic pain, sometimes it solves a lot of issues. So normalizing the base of support will pyramid upwards to your success and results. So I mean, you're also looking at stuff involved with the sacrum. Looking at your dural anchoring. Your phylum terminal. All the way down there. But you're also looking at your ganglion impar, which is on the anterior surface of your sacrum. Right. So all these type of structures affect or are affected by that sacrum coccyx mobility and positional location. Right, yeah. So it's just, looking at everything else. If we can adjust this and it solves all your problems, great, you're done. Yeah. So, I mean, you're also looking like fascial tension, normal stuff that we've all done before. And visceral, obviously, it's very close to your rectum, very close to your bladder. So that type of stuff. I have had patients with issues with regular menses. A 13-year-old girl, she started her menses at 10. So to me, that was young already. And then for her, she's like, oh, some days it's 5 days, some days it's 45 days. She's 13 now, and I was like, this is not normal. So I asked her, did anything happen when you were younger? And she actually fell when she was 9, right? Fell hard on her bottom, okay? And we're feeling around, and I'm like, hey, this is kind of weird, right? It's like way up in there, her base of her coccyx, and it's slightly side bent, and does this hurt? She's not here for that. She's here for low back pain. She has history of scoliosis. But then that combined with that sacrum coccyx improper positioning led to, I feel, her irregular stuff up here. I didn't treat her too much. Actually, Dawn and I co-treated her back when I first started. So Dawn was talking to me, oh, work this stuff, get that patient rapport, get that comfort zone, and then work it as much as you can. And at some point, her menses started to normalize around 45 days, which I feel that was a little bit better than, short days and then long times. So who knows? Yeah, treat all this stuff. Yeah, treat all this stuff. So going back to the coccyx, so the stuff that we're going to be looking at in terms of the coccyx is a lot of dysfunction, obviously. So you're looking, in your assessment, you're going to be looking at them in prone. A position, B, and that end feel. So in terms of IPA, they always say everything should have a springy end feel. Right? Push it should be springy. Even the elbow should be, quote unquote, springy. But it just depends on how springy you would call it. Right? But what is springy for each joint, you don't know. Ideally, you test both sides so that you can feel the difference. Right? Everyone okay with that? End feel, spring. Okay. So dysfunction that we would look at for the sacrum, you're looking at compression, rotation, anterior, posterior shear, flexion, extension, side bending. Okay. Everyone? Yeah. So today we're just going to focus on rotation, flexion, extension, and side bending. Compression is what it sounds like. It's when the sacrum on the coccyx is not moving. Treatment-wise, you would just separate it. You just take your two thumbs and you separate it. That is decompression. Rotation, right? Forward, backward on this guy. And then you would feel the transverse processes, the term would be lipping that they use. Basically, one is higher, one is lower, one is more pronounced, etc. The side bend, up, down. Obviously, that's the common sense, right? Up, down, side bending. And then anterior, posterior shear, forward, backward, right? That one I feel is always very difficult to treat and to feel because there's so many other tissues blocking forward and backwards. A lot of times, if you just feel a bilateral drop-off, that's a anterior shear. I feel that it's almost impossible to treat because you would have to go in. Okay, that is also correlated with flexion extension of the coccyx, okay, where it's dipped in, dipped forward, dipped, whatever, okay. So when you find someone with that flexion, excessive flexion of the coccyx, we're going to work on that a little bit externally, but at some point, if it's too sensitive and you can't mobilize it enough externally, there's always the internal option. Has anyone done the internal here? Nope. Okay, I've never done it either. Don says he's done it to a couple guys with ACL tears, and I don't know how that correlates, but he says it works. But if you think about the ACL, laxity, and all this type of stuff, that sacrum coccyx movement is going to play a part. So if you can extrapolate it to someone with an ACL, you can extrapolate it to someone with pain here. Side bend, we already covered that. Okay, so in terms of coupling, the more common motions that you'll feel are coupled side bend and rotation, okay? That's kind of the common sense. When you fall, you don't fall directly on your butt vertically. You often fall one side because you're grabbing the floor, you're trying to block your fall, and you feel that side bend or rotation. If you feel that treatment-wise, usually you have a good prognosis. Treatment-wise, if you feel side bend contralateral rotation, then you usually have more of a problem in terms of long-term prognosis and how to treat this area. So ipsilateral is more common and it's easier to treat. Contralateral, who knows? So in terms of treatment order, the IPA group, they recommend treating rotation, treating the shear, decompressing, side bending, etc. You guys can ask about that later, but this, in terms of sequence, that's how they recommend it. Okay? So obviously, functionally, when you look at the coccyx, how a person sits is going to determine sensitivity to that area, right? So anterior pelvic tilt, posterior pelvic tilt, you can tell where that pressure on the sacrum and the coccyx is going to come into play. So when they sit and they're mentioning, oh, I have pain on one side, pain on the other side, obviously, yes, localized to where they're feeling it and what causes that symptom. And then ideally, when you treat this, that is your before and after tests. You know, that's your star sign. So any other questions so far? Okay, confused, not confused? Alrighty, so we kind of talked about this right now. And then going back to this, how you were talking about what else is connected, obviously all the sacral nerves, the ganglion impar on the front, right? Organs, all that type of fun stuff, okay? So, where am I? Oh, wrong arrow. And then if you look posteriorly, if you guys want to get a bigger view of this guy, today we're feeling more of these two structures here, okay? The transverse processes of your coccyx. In addition, when we palpate the sacrum, you're going to be palpating a lot of the ILA, the inferior lateral angle here. A lot of times we focus so much on here because it's easy to feel and it's less tissue over there. But very important to look at down here because the SI joint is not a flat joint. It's kind of like a figure 8 kind of thing. And then when you feel that joint, it rotates based on that as well. So anterior, posterior rotation, that type of stuff affects superiorly versus inferiorly a little bit differently. And that's where I feel a lot of the lack of progress sometimes when we focus more on one area versus the encompassing the whole treatment area. Okay. Where's the arrow? Okay, so we're going to start with this stuff. Can I have Mike come up? Where'd he go? So today, working with everyone, that's kind of why I asked for lab clothes because you're going to be essentially going up in there, okay? Obviously, get consent. Mike, do we have consent to access your pelvic area? Okay. When you work with the patient, you know, if you're opposite sex, you know, ask for if they want a witness or something. I think I had Shelly witness for me once, and then, you know, get permission. Hey, are we allowed to go down there, even though it's close to their danger zone? Okay. And then they're like, oh, where? And then I tell them, oh, I'm going to be very close to your rectum. And then I start with the very broad grip. You know, I let them know, all right, we're going to start up top, Mike. Okay, we're going to start up there. And then I just start mashing around, and they're like, oh, okay. They're okay with that so far. And then I'm going to go down the middle. Okay, Mike, when I get too close, you let me know. Just say, okay? So I just start feeling around, all right? You guys normally focus on that PSAS range. Easy peasy, right? You guys would palpate that. Sorry, my hands are cold. All right, you feel that? Easy peasy. Before we keep going, do you have any discomfort or anything? On your PSAS? Okay. Both sides, he says. Okay, so that's good. At least it's both sides versus one side. I would say one side is a little bit more fun in terms of plan of care. All right, so you keep palpating, and then we're a little bit lower, right? You're still following your iliums. All right, and then you just keep going. And then as you get comfortable, as they're comfortable, you can start making your way down. Okay, we're gonna keep going lower, so just let me know. Okay. Okay, so that's why I kind of asked you guys to cut your nails today, because you will be doing a lot of finger DIP flexion. Okay, so there is your coccyx. Okay, and you guys can look. I'm very close to his dator zone. Okay, and then there are his transverse processes. Okay, so that's kind of where we're hanging out. Down here is the base, and you're hanging out more down here. Assessment wise, what we kind of talked about, that decompression, compression. Okay, so from here you're feeling the difference. You just kind of feel how well that springs. And he's actually got some good movement there, right? Are we okay with that so far? Okay. So as you can tell from the picture up there, just use a broad grip, and then feel with whatever finger you're most comfortable with. So you're feeling there, you're feeling there. Around you okay? Okay. Any sensitivity there on the left? Okay. So you can tell based on that, you're just feeling around. But actually, what I feel is his rotation. You're a little bit right rotated. Do you feel it's a little bit deeper on this guy? And then end feel wise, this actually feels okay, right? And watch your thumbs, guys. Obviously, you guys learned that in PT school. Hyperextending, flexing a little bit. Just be careful. Okay. And that right side, you can feel a little bit stiff, right? But end feel here is actually kind of good. Yeah, a little bit rotated right on his transverse processes. Okay, and then feeling up top, you're feeling for the side bend, right? Or you're feeling shear, right? You can shear it sideways for lateral shear. You kind of go digging on the side, digging on the other side, in, out, up. The left one's definitely sore. Okay. All right. So everyone's so far okay with compression and rotation? Okay, so what I would like for now actually is for everyone to practice with your partner rotation actually, or feeling rotation, because I feel that's the easiest one to feel. It's just deep in, out. When you're looking at it, you okay? You just checking. Yeah, just hands up on there on the transverse process. And then you're just feeling depth. You're just feeling depth. Okay? And then treatment for rotation.
I'm holding your call.
Treatment for rotation is mobile in the wrong direction, or in the correct direction, mobile away from the wrong direction. So you can see in the right picture, IPA, they always tell you to find the path most resistance, whatever has a lot of friction, a lot of give, or not a lot of give, and then just kind of work that end feel until it becomes springy or more similar where it should feel. Okay, so for him, I'm going to be giving that pressure over his right side, right? So I'm localizing that, and then play with your direction, feel your direction. Where I'm just blocking my thumb. Sorry, guys. Play with your direction. Feel what is incorrect, what is correct. All right. So as you're there, all right, that's kind of sore there, right? But you can feel that's a little bit hard and feel. So you find that. And then you can have that tension. You keep that there. You can keep working it. You work it. But if it at some point becomes sensitive, you can have the patient generate their own tension.
Sorry, your party on hold disconnected.
Okay. So with that rotation, all right, I like to hook their leg kind of like so. All right, you okay there? How does that feel compared to when your leg was down? More anterior glide. Okay. So that's kind of what we're going for, right? And then you can play with actually the rotation on that with the hip rotation. Okay, so using crook of your arm, that's kind of how I've done it. Depends on how you like to do it. If you like to use your hand, your armpit, whatever's comfortable for you based on your arm length. You okay so far? Alrighty. So if we could start with just that right now. Anyone have any questions before we break off?
I was curious if you get any patient feedback at all. Like, does this feel better? Does this feel worse?
So that would come in your test retests, whatever is best based on them. Right now, it's going to be sensitive, regardless, right? Because you're mashing on a structure that's stiff. So patient might tell you, hey, stop, stop, stop. Then yeah, stop, obviously. But if it tells you, oh yeah, I feel it stretching, yeah, keep working it, and then recheck. Hey, does that end feel correct now? Does it feel springy on both sides? So when you feel that, then maybe take a break, see what they feel like symptomatically when they're sitting, standing, moving around. Okay? Sorry, any other questions? Yes, Jack?
To go on the opposite side of, like if one side is more stiff, you're actually treating away from it?
No, not necessarily. So, Jack asked if one side is opposite, do we treat the stiffer side? Right.
Well, you said kind of, it's like counter what you would
Right rotation,
Yes. Yeah. So, I mean, you would treat it just like any other rotation, right? If the side of right rotation is what is incorrect, you would treat towards left rotation, which is I'm just digging in that right transverse processes to create left rotation. Okay. So if you guys could partner up, find a table. We've got 3 minutes a person to practice this technique. Assessing side bending. All right. So you had a little bit of side bend plus rotation, which what we talk about is common. With that side bending, I feel it's actually easier to treat in side lying. So side bending, the coccyx is going to be tilted one side. Let's say he is side bent. Wait, which way would I do it? All right, let's say he's side bent. I can't think right now. So then the technique is actually called the wishbone technique, right? So depending on the way that he's side bent, you're going to grab the femur. Okay, you can support it underneath your thigh or whatever you're comfortable with. I think in that picture, I was just using my hand for pictures aspect. But then from here, you have that, keep going a little bit more. Okay, you're palpating. You okay there so far? Okay. So from here, if you guys can see from back there actually, I'm just going to be on the lip of the side bend transverse process, and I'm just going to dig. Is that a little sensitive there? Yeah, and it is going to be sensitive. It's not a fun technique. We're just getting a little bit of pressure. I'm trying to go actually. Yeah. Yeah.
I can't see your hand, but is it just using
So yeah, I'm just using my DIPs. I'm just hooking a little bit, and then I'm just pushing down on that transverse process. You okay here? Okay. Yeah, that's true. Yeah. So we're just trying to dig a little bit. Oh, you feel that little pop? Okay, so a little bit of soft tissue probably would help also for you. But yeah, working on that area, and you feel that not fun, but working away from that side bend. Okay, so that's how I would treat the side bend versus in prone. It's tough to treat side bend like pushing this way.
That's why I was like,
Yeah.
one is not
Yeah.
going up, the other
Yeah.
is
Okay, so you can assess it in prone, but then treat in side lying. Okay, so from here, you would use other techniques to generate tension, right? So from here, you could have him do a hip adduction, right? And you feel that a little bit, okay? Go to relax, okay? You could have him do a pelvic floor contraction, all right? So you're just generating tension based on what else is connected in there. Okay, and you work on that, you feel what feels best, and then when it's comfortable, let that leg back down, okay, and have him reassess in prone, feel if it's any different, and then have him do his star sign, oh, it feels better, it feels worse when I'm sitting, standing, etc. Okay? Just for time's sake, we'll go into flexion extension, okay? So I don't know if you guys felt it on your partners, if they have any flexion or extension in their coccyxes. Anyone?
the flexion is more
Tucked, yeah. No, okay. So you're feeling that pencil tip, right? You're feeling that pencil tip, and it feels like if it just dips in, and you're like, hey, where'd it go? I would say it's inflection. If it feels like it's pointing back out at you, I would say that's extension. And if you don't, then great, yeah. Okay, so we'll just show you the side lying treat for flexion. Okay, so this is very important. Cut your nails for this technique. Okay, and have them wearing something a little bit more sheer. Okay, or if they're comfortable, you can have them lower their pants a little bit. Okay, because access for this is very, very sensitive. You're going to be hooking the front of the coccyx. Okay. So I showed you last time, and it's invasive. Yeah. Get consent. Do we have permission? Okay. Yeah. Okay, so can we actually show a little bit more? Okay, okay, you okay, Mike? Okay, so for him, you're kind of down, and then his coccyx is all the way down here. So you can tell how low it actually is. So I don't know if you guys are feeling probably here when you guys are feeling that base of the coccyx. You're like, oh yeah, I feel it. No, it's way down in here, and Mike feels that little bony tip, right? So we're here. This is where your either hand sanitizer gloves come in. Okay, I prefer using skin contact because it's easier to grip. Okay, and if you can't grip it, then you're just pulling soft tissue, and it's not fun. Okay, because this is a very sensitive area, a lot of tissues in there. So I'm on the front of his coccyx right now, a little bit, still a little bit. Yeah, so you are a little flexed. Yeah, you can feel it's way up in there, right? And it just feels like it disappears, but it's actually still going in, right? So for camera's sake, I'm not going to keep going in, okay? But I'm going to feel that. I'm going to try to hook it with the pad of my DIP from there, and then I just pull on it a little bit. Very little bit of bend tension, not a lot. You okay? How does that feel to you? Not bad, right? So for him, maybe I'm not going deep enough because I'm being modest here, but you're there, and then you really want to get that firm grip, pull on that a little bit. Okay, everyone have any questions so far? We're okay? You guys all kind of get the idea? I'm trying to hook, yeah, but I'm using just my DIP pad, okay? Yeah, where'd it go? No. So he'll tell you that his rectum is still about an inch away, right? About an inch away. So I'm really trying, use my other hand. Okay, we're really trying to go up on top into this area, and I'm trying to do this. Right, soft tissue wise, you're going to be probably around here, but then bony tissue wise, you're going to be gripping as much as you can right there on that tip of the coccyx. Okay, and you're just gently pulling right on the pad of your finger. Okay, right there, just hanging down there. If you guys want, try it at home later on yourself. Try to see how much tension you can generate yourself. Today for your partners, be nice. Okay, so when you're there, okay, we're gonna go back to that area. Okay, you can have him do a small pelvic tuck. Okay, can you tilt a little bit? Good. Yeah. Does that feel? Both directions. You would kind of just feel which one generates more tension. Okay. When you do that, that loosens a little bit, right? Yeah. Okay. So you're there and you're just tilting a little bit. Either that, or you would have them do like a little baby clam. Okay. Just a little bit, but that you feel that fingertip sometimes will slide. So that's where the sensitivity of your hand really comes into play. Okay. You okay so far? Alrighty. The other way to treat flexion is in quadruped or in hanging off the edge of the table, something supported. Okay, can you go into quadruped really quick? So that's the second picture. For better or worse terms, it looks like when you give a dog a pill, right? It looks suppository. Yeah, and that's kind of what it looks like. Okay, so you're here on that area. I prefer to use skin contact. Okay, you okay? Okay, so same thing. You kind of go down into his area, okay? You feel that bony tip, okay? Generate a little bit tension to pull it into extension, and then from him, you can either try cat camels, right? And that little bit there we go, right? And you feel that doesn't feel fun, right? And then just however much pressure you would need to create that movement, okay? Same thing, pelvic tilt, cat camels, working the T-spine, separating his hip, narrowing his hips, whatever will help you get that end feel a little bit better. In addition, the internal technique is where if you really can't do anything and the patient is fully on board with it, then you can try an internal technique, okay? You would have them prone or side lying, whatever will ease your access internally, and then gently hook. And then it's not a deep pressure. It's probably only about that much in, okay? It's not a large movement when you go in internally, per Kent Kaiser's description. Okay, I've never done it. Okay, so any big questions about flexion or side bending right now?
What do you find works best?
I prefer sideline because they're more relaxed. And then it's less, like I said, the dog example. They don't feel as much of a subject. They feel more like they're trying to treat something. Access-wise, this is easier. Yeah. But sorry, Shelly asks if I prefer a certain technique version for the side. No, that's the side lying versus the quadruped for flexion extension treatment. I mentioned that I prefer side lying because they're able to relax better. And then extension of the coccyx, you would just push it down. Easy peasy, right? Alrighty, let's break off for a couple minutes and let's try that out. You okay? Stuff that we've all done before, stuff that Lars was actually recommending before this stuff, but everyone has a different preference, whatever works best for you and your patient. Side lying, you work top of the iliac crest, tissue shortening, lengthening, functional mobilization. That's all stuff that we've done before. Visceral distraction from the anterior ilium. So if you're looking at, just distension from this area, or someone has a like an old hernia or something, all this type of stuff that's just pulling on this anterior ilium, that can affect how the position of this down there also is. Okay. Working the superior gluteals. So someone who has overactive glutes, that would, change the posture of your pelvis, obviously. Obturator internus. Has anyone done that before? Okay, so you can do it internally. You could also do it posteriorly. Not anterior. Yeah, so posteriorly, yeah, exactly what Tony's doing. You would have them in side lying. You're essentially reaching the inside of their ischotuberosity. Okay? Everyone okay with that? I like to tell people to do that to themselves because it's easier to do it actually in sitting. If you just literally go up in there and then you're palpating on yourself, you feel that ischotuberosity and you just kind of grind away. Okay? Inside of the ischotuberosity. Do you feel that?
We do it on the mount lower.
Yeah, so similar techniques that you could extrapolate to a lot of different things. It's just here. Just when you're doing your soft tissue. I just like to use my elbow because it covers more surface area. And obviously sacral sulcus and side lying. So that area, a lot of times that's where patients report a lot of that pain. I have pain at PICS. You push the joint, it's stuck, and then you feel all the stuff around it. It's lumpy. It feels like jelly beans in there, and you just want to pull it off and just smooth it out sometimes. Okay? Sacral assessment. This is all stuff that we are generally able to do because it's a bigger surface area, right? So stuff that you would test, lateral weight shifting, right? Just moving side to side, and you're feeling PSIS, ASIS to see how it moves. Looking at elevation, depression, abduction, adduction. Okay. In theory, an efficient SIJ should not move when you move laterally. Okay. The ASIS and PICS should just go horizontally. They should not go up, down, in, forward, out, all that type of stuff. That is as per the IPA model. And then leg swing is more of a functional movement when you're having them supported and then literally just kicking back and forth, and then you're feeling, do they have a hard end feel when their leg extends, snaps back into that PSIS into there. So with that springy end feel, generally if we assess the sacrum, we treat the sacrum, does that leg swing change? That is your before and after test. Okay. Sacral assessment, I apologize, we ran out of time. Everyone has done it. You just kind of push on the sacrum, feel it PA, you feel it forward, backward, inferior glide, right? You're feeling if it moves, going up and down. I don't think I included a picture. Unilateral versus bilateral. Just feeling L5 on the S1. Just feeling where does it give, does it not give, is it high, is it low? And then testing it with lower trunk rotation. So if they're prone, and then leg swinging. And then if they do have a dysfunction, that superior sacrum will go cranially. It should not in an efficient model. Okay, it should just be hanging out. Sacral treatment in prone, this is all stuff that we've done before. Other ways to generate treatment while you're doing those PAs is just to increase the knee extension, resist the knee extension, lower trunk rotation, hip rotation, and then obviously press ups like a upward dog kind of motion. Inferior glide, you can treat same thing with the knee bends, distraction, and then you can do percussion or with a Kong. Yeah, what Shelly's doing, you just gotta hit it. Okay, quick grade 5 kind of technique style. Yeah, but you look like you have a question. So if I'm on the PA while I'm doing an inferior glide, right, and then I'm just like, okay, it's not moving, I would just want to do something quick. I can take my thumb, or I can use a Kong, which IPA sells. It's like a little plastic rubber thing. Just put it on there, percuss it, and I'm just percussing into that inferior glide, okay, towards inferior, or your thumb if you're comfortable hitting your thumb. Okay. Okay, so we didn't do this stuff. Inferior glide, you guys kind of got the idea. Pro knee bends. And then indominant stuff, this is the easy stuff that everyone knows how to do, right? Per se, yes. Any big questions there? No. Depression, elevation, external, internal rotation, in-flare, out-flare, that means up, down, anterior, posterior rotation. Yeah, good. Any big questions? Okay, Therex. So stuff that you would do functionally after they do all these joint mobilizations. How do I keep them moving? Basking seal. You guys ever seen a basking seal? They're on their side and they kind of kick up. Do you guys need me to need Mike to demonstrate that? So let's say we've been working sideline. We've been working on his side bending and stuff, and then he's rotating a little bit better. So from here, Mike, can we connect your upper and lower trunk and just kind of do it like almost like a side crunch? Come up here also. So he's moving from here, and then you can functionally mobilize that as well. Okay, so you can tell how his sacrum would be moving here, right? And we're working that. But you can tell he's easier moving down there, but he's up here. He can't control it too much. So you can help. You can MWM with it, okay? And yeah, that's how you do the basking seal. Innominate extension and sideline. Has ever done that? Nope. Okay. Can you prop this leg kind of like so? Okay. And then from there, I'm going to support him upwards. Okay. So he should feel that innominate moving into extension a little bit, right? It's kind of weird, but you kind of see how that would be an active motion. This, though, is obviously aggressive. She's got a face going on, right? Very aggressive. If a patient has knee pain, don't try it, right? Supine or prone hip internal, external rotation. Can you go supine really quick? So if you have him supine, this one's resting, right? You could tie like a TheraBand to this, and you can have him just work in that internal, external rotation if he has the symptoms before, and then just training now how to move it, now having moved his proximal structures. Okay, single leg balance. Yeah, you guys got that? Okay, Superman's obviously in prone. Sideline wall pushing, so just working that hip extension into the wall, feeling that pressure buildup. Standing wall marches. Okay, he's just into the wall, feeling that contraction, extension of his movement of his innominates, and bridges and climbs like everyone does. Okay, sorry, ran out of time. Sorry.